Good morning. Good morning and welcome to the last day of our wonderful summit.
Okay from down there?
I think we're okay.
Okay.
And I want to welcome you to the 5th annual Debra L. Spunt Lecture. I'm Mary Ann Rizzolo, and I was privileged to know Debbie Spunt. She was part of the first NLN Laerdal simulation study, our 3-year multi-site, multi-method research project that led to the development and testing of the NLN Jeffries framework and the publication of the book, Simulation in Nursing Education, From Conceptualization to Evaluation. Debra was a valuable member of our team, and she was nationally and internationally recognized for her knowledge, expertise, and leadership. When Tor Laerdal became aware that Debbie was terminally ill, he contacted the NLN to establish a way to honor all that she had done for simulation in nursing. I visited Debbie just a few days before she died to tell her about this lecture that was being established in her name, and I can tell you she was thrilled and honored. Debbie selected Pam Jeffries to be the first to deliver this lecture. In the 3 years that followed, Carolyn Yoakum from the University of Maryland, where Deb worked, Rosie Patterson from Laerdal, and I met to select the subsequent Spunt lectures. I can tell you that each of them was unanimously selected and endorsed. In 2008, our second Spunt lecture was Dr. Janet Grady, who is right here on our left. She was selected for her innovative work in telehealth and simulation, which she was able to do with funding from the Department of Defense. Quite an accomplishment. In 2009, Dr. Sharon Decker, who was also part of our NLN Laerdal simulation study team, along with Pam and Debbie, was our Spunt lecturer. And now she holds the Covenant Health Endowed Chair at Texas Tech. In 2010, last year, it was Dr. Susie Cardon-Edgren, who was part of the second NLN Laerdal initiative that developed the SIRC, the Simulation Innovation Resource Center website. And she is the editor of Clinical Simulation in Nursing, where all those wonderful articles on simulation are published. When it came time to consider who would be our 2011 Spunt lecturer, Rosie Patterson of Laerdal suggested that we bring all of them back to discuss what has happened in the last 5 years. And we all agreed that this was a fitting way to use this event, generously funded by Laerdal, and to once again celebrate Debbie Spunt's life and accomplishments. Each of these women on the stage before you is passionate about simulation, and their tireless work has moved the use of simulation forward by leaps and bounds. I could spend many minutes talking about all the contributions that each of them has made to this rapidly evolving approach to teaching, learning, and assessment. But it's more important to hear what they have to tell you this morning. So let's listen as they discuss where we've been and where we're going with simulation in the years ahead. But before we begin, my colleagues have asked me to provide you with their agreed-upon working definitions of simulation and fidelity, so that when you hear those words as they discuss, you'll know what they mean. For simulation, we're talking about a technique and not a technology. A technique that uses a situation or environment created to allow persons to experience a representation of a real event for the purpose of practice, learning, evaluation, testing, or to gain an understanding of systems or human actions. When they mention the word fidelity, they're talking about the degree to which either a simulation encounter or simulation equipment approaches reality. They're not talking about the degree of realism within the simulator or the mannequin. So let's listen as they discuss where we've been and where we're going.
Thanks, Mary Ann. I guess the first question I'd like to ask my colleagues, is simulation just a fad that will go away?
Well, I'm going to say no. And the reason I'm going to say no is every day when we bring in prospective students, one of the questions they ask us is, where's the Sim Center? How many hours are we going to spend in simulation? How do the faculty utilize it? How is it going to help my learning? So I believe if it was a fad, students wouldn't know about it to the extent they do. And I mean, not just that it's an experience and it's fun, but they want to know how it is going to improve their learning.
I think that you know it's not a fad when there's federal funding for it. And AHRQ has now had 4 funding cycles for simulation related to patient safety. And that last one, perhaps there are some people in the audience who also submitted AHRQ grants yesterday or today are the closing dates for that. So when the government funds it, I don't think it's a fad.
Okay. In addition to AHRQ grants, I know most recently there were those ERA grants also for equipment. That was really good. And when the feds speak, that speaks volumes actually. Also, I look at simulation centers being built, not only just regionally and statewide, but worldwide. There's much investment going on. So to me, that explains and really provides the evidence that this is not just a fad. So. Okay.
Another question that I have for all of us is what evidence do we have that what we are currently doing, for example, using PowerPoints, taking our students to the clinical setting, really works and really improves clinical practice?
Well, we're going to talk a lot more, I know, about the evidence that we have that simulation works and what we know and what we still need to know about simulation. But I think people, maybe forget, or maybe we just don't like to acknowledge that we really don't have a lot of evidence that what we currently do works. As a matter of fact, I think we have a lot of evidence that what we currently do really doesn't work. A few years ago, you're probably all here, we all had the privilege of listening to Dr. Lee Schulman from the Carnegie Foundation. Remember that lecture? He was talking about signature pedagogies and talked about the Carnegie Foundation's report. And one of the very significant things that they found was this huge gap between the world of nursing practice and the way nurses are prepared for that world. It's a huge gap. I guess maybe I'm just getting old, but I can remember when we first talked about reality shock, back in the 70s. And I think it's worse today. Do you think? I think it's way worse today. I think that the students are really experiencing this huge cognitive dissonance that folks are writing about, this difference between what they see in the classroom and how they're instructed, and then what the real world of practice is like. So I think we're sort of perpetuating that. Maybe, I don't know, I'm ready to assume some guilt for that. I think we all should. But there are a lot of folks, and there's a lot of information in the literature about how our graduate nurses really aren't functioning the way we think they should be functioning. And one person who's written a lot about this is Dorothy Del Bueno. And she's been involved with this performance-based development system that over the course of maybe 20 years has looked at the competencies of new graduates. And what she has found through a series of sort of patient-centered exercises that have told us a lot about the competency level and the critical thinking skills and abilities of new graduates. And what she's found essentially is that only about 35% of new grads meet entry expectations for clinical competence. 35%. So that leaves another 65% who have passed NCLEX, right? They've passed NCLEX, so they have the content. They know what they're supposed to be doing. Maybe they even know how they're supposed to be doing it, but the reality is they're not able to demonstrate that. 65%, I think it's very scary. I don't know whether it's maybe comforting or maybe it's even disheartening to really look into the literature and find that this isn't just happening in our country, right? I mean, there's studies from Australia and South Africa and a lot of other places that show patient incidents involving things that really are related to the lack of competence of new graduates. A lot of data out there. I don't know. Maybe we might ask each other, how do we know that this data are accurate? How do we know that these data are accurate? Well, I think that one way that we know they're accurate is that these data are coming from a number of sources. There was a study that Dr. Marilyn Orman did where she questioned nurse managers. And a lot of these nurse managers said that really graduate nurses from all levels of pre-licensure education. I think that's another main point. It's not one type of program versus another, but graduates from all types of pre-nursing programs were found not to have sufficient levels of competence. And one other study I want to mention is a study that was done by Burkow and colleagues. It was published, I believe, in '09. And this was a study that I think a lot of folks in our audience here are probably aware of, where they identified 36 basic competencies of new nurses. And then they had these nurse executives prioritize these competencies. And guess what competencies ended up at the very bottom? They were prioritized in order of how they perceived their new grads, to what extent they perceived their new grads had these competencies. And the ones that were at the very bottom, in other words, that they felt they perceived less in their new grads, were prioritization, right? Delegation, things that we think these nurses should be able to do, providing rationale for their actions. So I think the folks who are saying that the way we do clinical now, the way we do teaching now is really random access opportunity, probably right. It's a crisis. We need to do something about it. I think SIM is going to help.
I think another thing we should think about is that in the United States today, in the National Simulation Study that surveyed 1,700 schools of nursing, the range of clinical hours is 0 to 1,600, and everybody sits for the same NCLEX. So 0 to 1,600, that tells you a lot. Another thing, I just want to throw this in as we're maybe closing out this topic here, or maybe people have more to say. Okay, another point is that this theory-practice gap, I have a doctoral student right now working on a paper as I'm sitting here, and her concept analysis is on theory-practice gap, and it's across all disciplines. So this is not just a problem in nursing, this is a problem in higher ed across the board. So I don't know if it's comforting or horrifying, but we've all got the same problem, and I think higher academia is going to be taking a closer look at all of this.
Medicine's acknowledged too. They
Yes.
have the same problem in medicine.
Yes.
They're
On the
calling-
theory-practice gap, it was in 2008, there was an Executive Nurse Advisory Council, and they surveyed nurse executives, managers, in addition to nurse educators, to ask how prepared the students were when they graduated, going back to your point. And nurse educators said that 90% of the students were prepared to go out to practice, and the managers, executives, 11%. So you have 90%, 11%, that's a huge gap. So sometimes I think in education we make a lot of assumptions that they are prepared until you start getting the evidence and the data. And one other contribution I want to make is, this goes back, I think, when online teaching came about, and we had to get all the evidence and the gold standards of traditional learning in classroom. We have lots of evidence about that and online. And now simulation, we have to compare, I think, with clinical education today. That's kind of the gold standard. But if you look at the evidence, just as you were pointing out, Janet, there's studies, but they're small. The methods are not rigorous. They're usually one outcome and one school studies. So it's hard to compare, but yet we continue, of course, to strive to get the evidence. So.
And we haven't done a great job with really evaluating the evidence for what we do in nursing education. In fact, the paper that I think I'm aware of was done by Nancy Spector for the National Council of State Boards of Nursing. You can find it on the website of the National Council if you know where to look, and that's challenging. It's not well organized. But the only two things that really have what we might call level 1 evidence are distance education and simulation. Everything else was less than that, which tells us that if you're into research in nursing ed, the sky's the limit. There are a lot of things left to study, lots of work to do.
Right. Well, I don't think there's a lot of folks here who would argue with us that we don't have a lot of good evidence supporting that what we currently do works and should continue to be held up as the gold standard. So what evidence then do we have that simulation works?
Well, that's my cue. And I am delighted to say that there are more and more meta-analyses coming out now. The struggle when you have a new journal like Clinical Simulation in Nursing is that people have to find you. So many of the meta-analyses that have come out in the past 3 years included no articles from Clinical Simulation in Nursing because people didn't know it existed. And so when they're saying there are no studies about X, I'm thinking, well, I have 6. And there are no studies about this, and I think, well, we have 5. Our articles are now starting to show up in the literature, but the most important study that has come out in the last 2 months was on the September 7th issue of the Journal of the American Medical Association, and because it was so new, it didn't make it onto your reading list. The lead author is Cook, and they did a meta-analysis of all of the simulation articles in all languages for medicine, for nursing, for dentistry, for paramedics, for nursing, for anything that was out there. Out of those 10,000 articles, they reviewed 607, and they did effect sizes. And what they found was the effect size was greater than 1 for almost everything except for change in patient outcomes. And the reason for that was that it was only a medium effect size for that is because there's so few studies done on that and because they're so hard to do. So within the nursing world, there are some recent meta-analyses of articles that show that yes, it does change clinical reasoning or critical thinking, and that's always a debate on what is the definition of that. And for each of those studies, you really have to look at how is it defined. So again, we need to look with caution at those particular things, but does it change behavior? Yes. Does it change confidence and confidence? Yes. I am leery of that because sometimes what we find is that now students are unconsciously incompetent. They feel really, really good about what they did, but the patient died. And I will never make that mistake again, except that if you put them right back into the simulation, yes, they do. So I am really a great believer in debriefing and then repeating the scenario and trying to let them leave demonstrating that they indeed have learned something or that they can now transfer the skills they learned to another type of situation.
A couple of other areas where we have strong evidence where simulations work is the performance-based sims, whether it's like pediatric resuscitation, the rescue. Lots of evidence in the medical literature, and it's coming into the nursing. That's grand. And another one that medicine's done a long time and nursing's catching on is that deliberative practice curriculum. And what deliberative practice curriculum is when there's very specific objectives and it's competency-based, so students know when they reach level 1, then they can proceed to level 2, level 3, et cetera, but they cannot proceed until those competencies are obtained. In your nursing education perspective journal that everybody got in their bag, there's 2 articles talking about deliberative curriculum, practice curriculum. One was done by Susie in the CPR study, and the other one was done by myself and a multi-site team using Harvey the simulator. And we were using deliberative practice to look at cardiovascular technique and assessment. But if you look at the articles based around that type of curriculum, the methodology, it works. It's very significant from pre and post testing. So we're coming along, I would say, with the evidence, but there's still many gaps, which we'll talk about.
One of the interesting things I think about the deliberate practice model is there are a lot of characteristics of simulation that are there. And as you said, Pam, we haven't been using the deliberate practice model in nursing for a long time, but it's been around forever in medicine, and they've shown really good, not only student performance outcomes, but also positive patient outcomes. Mm-hmm. A lot of studies out there. Mm-hmm. But one of the things with deliberate practice, in addition to the obvious practice component, is the feedback. Right? Mm-hmm. A lot of feedback. And doesn't that sound like coaching? Doesn't that sound like expert coaching? Doesn't that sound like Dr. Schulman? I mean, it's what we do in nursing.
And if you look at deliberate practice, you have to go outside of our literature and outside of medicine, and you look and see that they've used it and done research with chess players, with musicians, with athletes. So it's the theory base did not just start today. They have the research to prove that it really does work.
Right.
I like to use the example when I talk to people about deliberate practice, and I'll say to them, do you think Michael Johnson went out and did his free throw for the first time when he was playing basketball? No, he practiced hours and hours and hours. So when he was on the line, it meant something. And we can learn from others if we look outside our literature.
Good point.
A great example of that is we know from research done by the NLN surveys of our clinical faculty is that we spend 69% of our time when we're at clinical watching a student do a skill. Why are we doing that? Because we know that even though they were checked off, they really don't know how to do it yet. And so if we really went to a deliberative practice model, which means that they don't just get checked off and then theoretically they know it, is that they need to keep going back and doing it again and again and again and again till they reach that I can do it without thinking about it, the way we know how to spike IV bags and things like that without thinking about it.
And combining the deliberate practice model with simulation really, I think, addresses another area that we see a lot in students. I mean, how often do we see students that can do the skill, maybe they can achieve satisfactorily or almost at every level until it comes to putting the whole thing together.
Yes.
And then you just say, well, boy, they made it the whole way along. Now, why can't they put that together? Well, here's where simulation, because of the context, right? We're not looking at just individual skills performed in isolation, but we're looking at the whole context. And the degree to which the simulation, whether it's high fidelity simulation or standardized patients or role playing, whatever level or whatever type of simulation it is, to the extent that we can increase the fidelity and the realism, I think, and put it in context is really going to help that transfer of training piece.
One of my favorite quotes from one of my students was, "That was hard." And I said, well, you know, and debrief, and talk to me about why you felt it was hard. You made me think on my feet. And that is simulation. If I can have the scenario so real that they have to think while they're doing, I've achieved something.
That is very true. If you're looking for a citation to help you or give you the backup that you need to talk about this with your own faculty, look for Spiro, Feltovich, and Colson, which did not make it onto your reading list. If you just type those three names in, they talk about the ill-structuredness of the clinical environment. And it's for medicine and for nursing, and that we teach skills with no context. So once it's with context, like the patient's talking to you or their kids are running around underneath your feet while you're trying to put in the Foley catheter, that's why students have trouble, because they've never done it the way it's happened. Do we have time for one more story?
Just one more story,
Okay.
and we'll transition on.
I am a living proof that this really is true, and that how many of us have CPR 50,000 times? Raise your hands, raise your hands. Okay, the first time I had to do CPR really was in the aisle of an airplane. And as I looked around and I was thinking, trying to figure out, where do I put my butt? How do I do this? Please, sir, can you get out of your seat so I can get to where I need to be? I thought, this doesn't look anything like how I've ever done this. This person has arms and legs and I'm in a row of seats in an airplane. And so that's when I had the bubble appear above my head, and I thought, this is what it's like for our students in simulation, only this was me and it was a real patient on the ground. So I have experienced it, I'm sure many of you have too, is that you realize context. This doesn't look like how we teach. So.
Okay, great.
Great. So my question then for our group is, what don't we know about simulation? We're saying it works, but what research needs to be done?
Wow, where do we start? Well, what has been done, it was a year ago, June, we had the Ustein Conference in Copenhagen, and it was a group of medicine and nursing, about 24 participants. And a research agenda for education and simulation was outlined, and it's in the Simulation and Healthcare Journal that just came out this past summer. In addition, something through the Society in Simulation and Healthcare, it was last January, we had a research consensus summit. There were 11 task force, excuse me, 11 task force looking at different research topics, one on debriefing, one on assessment and all that. And those monographs came out just about a month ago in August. They're wonderful. They're packed full of the references and those covered with the research. And lastly, I'll make one more statement and before I move on. What needs to be done and is being done is through the National Council State Board of Nursing. This fall, they embarked on a multi-site across 10 schools, a national study. And it's for many purposes, but one is to answer the question that many regulatory boards have had, in addition to faculty and leaders in schools, is how much simulation can be substituted for clinical practice. And if you look across the 50 states, it's being done differently. Some states, regulatory bodies, they don't care. They're just going to watchfully monitor the boards. In Florida, California, they've set the line for 25% to substitute, and that's without evidence, but that's where they've drawn the line. State of Ohio, they say you can't substitute clinical sims for real clinical. So with the state board, we're looking at the 10 schools. Students are going to be randomized into 3 groups. One is a control, another one is substituting 25% simulations for clinical practice, and the third group's 50%. That's across 7 core clinical courses, including like fundamentals, OB, peds, psych, adult 1, advanced adult, and community health. So what I like about the study, not only are we looking at the dose of clinical simulations, but it's going to be in an organized, methodical method, and that's what we need right now. There's smatterings, so it's really hard to tell if there's a difference in our new graduates with simulations when it's just interspersed here and there. 1 course here, 5 courses here, and it's all over. So this is very structured. Some of the outcomes being looked at, one is clinical competency. What's clinical competency look like with these new grads at year 1, year 2, level 1, level 2, that's being monitored throughout, and compared with the control and then the doses of 25, 50%. In addition, knowledge is being measured, the standardized knowledge through ATI, the standardized testing across 10 schools, because we know there are 10 different curricula. There are other outcome measures, but those are big ones. And to control the integrity of the study, 54 people have been trained across 10 schools to ensure that, so the sims are being delivered in the same manner. In addition, the project coordinators at each school will be do testing using the DASH, making sure that debriefing is done in a meaningful way and all that. And one other piece of evidence that's greatly needed that the National Council is doing is that transition to practice. The 3rd year, a cohort of students are going to be followed from every school into practice, looking at what the orientation time's like, their clinical competency at month 1, year 3, or month 3rd and 6th month. So I think that's so greatly needed, and now's the time to capture that. It's not just about the dosing, the amount, which we need the evidence, but it's really about the competency. Are we making a difference? And I think a serendipitous finding will be, through this study, will be what are best practice for the simulations, because we're giving so much dose of sim, and we're really, it's the simulations that are being delivered are ones that were surveyed from faculty. NACSO did a survey along with National Council asking the faculty, for instance, a PEDS factory, what are your top 20 critical health disruptions you want taught, 100% of your students you'd like for them to have, in addition to what behaviors. So those have dictated what simulations in the curriculum are going into the National Council. So stay tuned for 2 years. You'll get some of the outcomes of that, and I'm very excited.
How are they going to measure clinical competence in that study? Because I think one of the things that folks struggle with is how to measure. You know, and we're talking about what do we already know. There's a lot of studies that have looked at confidence. We know students feel more confident and more self-efficacious, and maybe that helps them to make changes, and maybe that helps them to work better in the face of, a conflicted environment. But how will they measure clinical competence? Because I think we're sort of past that. We know it's a satisfying experience. We know they like it, et cetera.
Okay. We're actually doing scenarios that there's another study out there going on, the high stakes thing study or concept testing idea for the national NLN. The scenarios that are being written for that are from a wonderful team led by Pam. Those scenarios, there's so much synergy here because we're working on both of those projects together. We said, why don't we see if we can use those scenarios at the end of year 1 of the students who are in our study to evaluate their competence, and we're looking at what tools will we use for those, and then for end of program. So there's a lot of synergy between groups working together, scenarios that have been done, and they are high-level scenarios. So they've been validated, they're being piloted right now, they'll be tested with another group before, with an NLN high-stakes concept study before we hit the National Council study. So we are delighted that groups are working together and cross-pollinating that way and reusing these things, and that we hope to keep hold dear and not necessarily spread around, because they could be models for the future.
Okay, but,
So
but allow me to
competency.
one more question.
Yes.
The metrics.
The
What
metrics.
exactly are you going to measure to determine clinical competence?
We have some tools that are being used, the Quint level competency, which is a modification of the Lassiter tool, and then a modification of the a Creighton tool, the CSEI. We modified that tool using more CUSIN competencies, and it's now called the CCEI. Actually, the person who did that work for us on the CCEI is in the audience, Mary Keegan from here in Florida. And so the reliability and validity of those tools has been evaluated, and those will be the two tools that we will use.
So there are tools. I think that's
Yes.
a very important point. There are valid, reliable tools that exist to measure the things that we really want to measure.
Some
Yes.
of the, sorry, some of the subconcepts in the clinical competency, and that's how we define clinical competency, was assessment, communications, safety, interventions. So they're all spelled out. There are like 5 or 6 subscales that we use to operationalize clinical competency. This tool did.
Okay.
I'd like to take another shift and talk about one more area I think we still need research, and that is looking at how can simulation be utilized to teach and also assess teamwork. Utilizing, we have tools out there, we have team steps. I think we're looking at, a lot of us are using it within our school, but how do we go and get multi-studies looking at team steps? Because one of the questions they ask is, if I teach my students how to utilize team steps and they're taught in a group of students, tomorrow transition, they're in the hospital setting, that team may not be the team they were taught with.
That's right.
So do they transition? Are they able to work in a completely different environment, a completely different team, and still utilize the tools correctly? So
That's
I
great,
think that's
Sharon.
another
I think
area.
you're going to see more of that teamwork with the safety, the quality, and particularly about the interprofessional education that's going to be, so touted, which we'll get to in a minute.
So should I pose the next question?
Please do.
Okay, so
Yeah.
where do you see simulation when we're looking at interprofessional education? Does it have a role?
What about team training? Can we talk about team training too with that in terms of role? Because I think there have been a lot of studies looking just at nurses and nurses working in groups. But, going back to what I was trying to, make a point in the very beginning, is that I don't necessarily, no, not necessarily, take that word out of there. I don't think that's the real world.
Right.
Nurses don't really function individually and in a silo or a vacuum, right? Nurses are part of teams. And I think a lot of times students get out into the real world and they just don't have that concept at all, and they find themselves in these really strange situations. There's the reality shock. So how can SIM help with team training? And what are the questions around team training that we need? People assign roles to students, and somebody's the observer and somebody's the physician and somebody's I don't know, is that the right way?
I don't know if we know what is the right way, and what is the right modality that we should use to teach different skills. And as I look at it, I know my skill set. I know where I think I'm an expert with. There are so many different modalities of simulation that I still need to explore. I still need to develop my skills to help others. Would the modality be in a virtual world? If they were taught those skills in a virtual world, could they then pull it into actual world? I think it's wide open for us.
I think more of this is going to be evolving, but there are several scales out there now for teams. One is just a readiness indicator, if you're ready for
Right.
interdisciplinary
That's right.
education. Do you have the respect for the other discipline and all that? It's a ripple scale. But there are many scales out there just about teamwork communication.
Right.
Collaborative communication, I think that's one of the first steps to look at. And then, of course, you mentioned the team step curriculum and there are outcomes to that that can be measured.
You know what I think would be a really cool study? If we could look at if simulation improves communication and collaboration. And maybe it's a dose response thing. Are there different kinds of sims or different levels of sims? And then if we could relate that, because it's sort of a no-brainer to think that the increased collaboration is going to happen, right? So then what? You know, it would be really, I think, interesting, and it's something we need to do, to maybe correlate increases in collaboration with actual changes in performance and ultimately patient outcomes. And so what's the benefit of increased collaboration, other than everybody understanding everybody else's role and all that? That's great and wonderful, but the real nitty-gritty is what's it going to do clinically?
And Janet, what you're saying to me is that we've also got to get past our boundaries of we do simulation with my school or the schools around. How about we do simulation with my practice partners and bring my students into those sim experiences and vice versa, because they have to have and be able to develop some of those relationships with individuals that are already practicing.
And those studies have been done. They're few and far between. On your reading list, there's an article that Tim Dracott's the one that stands out the most to me. His name is in that list. And where those studies have been done are mostly in Britain or countries where there's socialized medicine, where if the government tells you everybody's going to do this, you do it. And what they did was they started working with collaborative team training in OB, and that's my area, so I really appreciate what they have done. And when they had everybody trained in a high-risk OB and deliveries of things like shoulder dystocias, what they found was they improved 5-minute APGARs by 75%. They decreased shoulder dystocias by 90%, because they had all trained together as a team and they had learned how to communicate and how to work together. So very hard studies to do. It has been done. You have some references for that. And that team, and the first author's name is SISS something, I don't know how to pronounce it, but Tim Dracott's on there. That team takes turns in who's going to be the lead author. They've done at least 7 different publications. When you need, does it make a difference in practice, there is work out there, and those are probably the most noted teams for doing that.
Okay. I think the ultimate is with simulation, what's the impact on patient outcomes? And that's where we've got to go. As you know, with any grant funding, you're more apt to get your grant funded when it's tied to patient outcomes, to safety over here, even though the education makes a difference, and that's the intervention, that's what we're talking about, but how does that tie? And we have to look at those quality indicators and patient outcomes over here. So that's where we need to continue to go, and I think the teamwork is going to make a difference. You just cited some, but there's a lot to go yet. But that's the evolution.
Haven't I heard that lack of communication is responsible for a lot of sentinel events?
That's right.
You know, I mean,
Absolutely.
we really need to be
70%.
looking. Yeah, we really need to be looking there. Can we talk a little bit? I mean, are we finished talking about interprofessional education?
There's one other thing I wanted to mention. Here, we just had an IPE think tank. It was Thursday evening here to look at nursing's perspective on simulation-based interprofessional education. We feel that simulations probably are the mechanism for IPE, for them to develop. So we met Thursday as a nursing team that represented different schools and groups to take it to the SSIH, the Society in Simulation Big Conference in January. It's called the IMSH. It's in San Diego. But there's going to be a pre-conference for IPE on a Friday and Saturday morning in San Diego. And what's really going to be awesome, different groups are going to come in from medicine, from pharmacy, public health, surgeries, nursing, and really come together and try to create a white paper on simulation-based IPE and what that looks like. What are some of the guiding principles, operating principles, whatever? What are first steps? What are priorities? Can we collectively get together as a group, which we are, and put that white paper and try to impact, policy, guidelines, practice actually, as well as education. So that's forthcoming,
Wow.
very exciting.
That is exciting.
Yeah.
I've heard several times, or the words in this conference, it's the time for IPE has come. And I think we're on the cusp. I think not just nursing, but all the disciplines, all our professions understand the importance of interprofessional teamwork, working together, and we're having agencies, government, accreditations say to us, do it. And it's kind of amazing that sometimes we hear it. I mean, they've been telling us to do interprofessional education since the Pew Report, even before then. And, we're slow. And it's not until Big Brother comes down and says, now's the time. You either do it, and if you don't do it, we're going to make you do it. And then we wake up, and then we start moving. So I think we're at that cusp right now, and that we're going to see the movement happen.
I heard the IOM said we should be doing that.
Well, the
Yes.
IOM are
thought it.
essentials, baccalaureate essentials,
The
other
Carnegie
documents.
Foundation.
Right,
Yes,
we're to do it.
amazing.
And you know what? We talk the talk a lot, and you look, different places talk. Even I know when I was going around see different simulation centers, wanted to see interdisciplinary centers, they'd say, yes, we do interdisciplinary education, all that. But what they met in the center, nurses were on Wednesday and
Yes,
doctors on
still
Thursday.
siloed.
They were
Right,
not together at
right.
all. And it's the walk that must be done, and that's hard. And as we always hear, it's the barriers. Medical school
Right.
schedule is different than nursing, or your health science schedule is different. But now, when we talked with the think tank Thursday, it's like, let's really make it happen. How can you, crosswalk those competencies? In addition, to make it sustainable, you have to integrate it in the curriculum. Right now, we do a great job of elective here, activities
Right.
here, an interest group here. But how can you really, really integrate an IPE element within the curriculum? Not even one semester across the
Across.
the
Right.
And
And
program.
maybe
it can't be
standardize it
volunteer.
too, so
Yeah.
that
Right.
it can be measured across.
Yeah.
Right.
We heard a great example. I want to say it was in our think tank here. It was University of Colorado.
Yeah.
Some people from there stood up and said, we have a new building, but it is health sciences building. They have everybody mixed together, and you can't tell where medicine begins and nursing ends, and the other allied health professions. And I thought that was a wonderful example for all of us to think about, because that is really taking it the next step, I think.
And they're cited for that, innovation for IPE. In addition, if people didn't know, it was May this year, 2011, interprofessional competencies came out.
Right.
There was a blue ribbon expert panel that came and described these 4 competencies for IPE, values and ethics being one, communication, teamwork, and roles and responsibilities. So with that coming out, I think that provides a structure for everyone to work around if they agree. And I know from the nursing point, we wanted to endorse those, which will go to IMSH when we do that pre-conference. So.
Excellent.
I just want to say one thing for small schools, small schools, because I think there's probably a lot of folks in the audience that are from places, and they're probably thinking, you know what, I don't have access to major academic medical centers, and I don't have a school of medicine like maybe Colorado might have in some of these other places. And I thought the same thing. Sometimes I feel sorry for myself, And then I look around and I think there's a lot of us that are in this same boat. So in my school, where we have a new program, the only other health science, well, not the only other, but one of the larger health science areas that we have access to are respiratory care students. So this past year, nursing and respiratory care never worked together, even though we're in the same division, but hardly ever cross paths. So we brought the respiratory care students into the sim lab and broke them up in dyads, and we compared how the nursing students did. It was just a little pilot, but we compared how the nursing students did working together just with nursing students. Then we paired the dyads, one nursing student, one respiratory care student. And we used a sort of a version of Lassiter's scale to look at actually their performance, their behaviors. And we found that when the dyads were composed of nursing and respiratory care, they hit a lot more of the critical indicators. And we're going to repeat this in this coming year, but a small school, a small program, not a lot of access, but we're able to get the students to start at least to think outside of nursing. So it's not, you know, interprofessional education up here, but it's certainly getting us thinking.
And what you're talking about is that ability of a team to think. And when we think as a team, I build on my strengths, you build on your strengths, and we add to each other for the patient and for patient safety. The other thing I'd like to stress is it doesn't have to be, when we look at interprofessional education, it doesn't have to be healthcare. It can be individuals outside, that we think outside of healthcare, social work, the clergy, dietary. Those individuals need to be brought into the interprofessional teamwork, that we work as a team. I know there's some places and practice that are working on it. They literally take their secretaries through team steps, the allied individuals, housekeeping, and bring them as part of the team. So there's a lot of work to be done, but there's so many opportunities for us to explore.
Right.
Good point.
Can I go on?
Okay, yeah.
You know, I think no matter whether we're talking about IPE on a large scale or on a small scale or whatever, one of the big barriers, I think, I'm going to say it, barriers, is probably that faculty. Could this be true, that faculty are sometimes hesitant to do new things? Could faculty be afraid? Could there be some resistance on the part of faculty? I mean, is it their fault, or do we just need better ways to provide faculty development?
I'll start with that. I think it's both. I think that I look at our schools and I look at the educational component a lot of our schools, and where I wonder, where did they put simulation? Where are we helping our new educators understand the pedagogy of simulation, what should be done? Is it an add-on feature, or is it ingrained in the curriculum? So part of it is our fault, that we need to explore, advance. I think we need to look at, when I say simulation, a lot of people have just one picture of simulation. There are so many modalities of simulation, and as I mentioned, I know where I need work. And so goes back to that other piece, it's now my responsibility to seek out that extra education, the extra knowledge, the skills, the attitudes that I need to expand my skills when it comes to simulation. So it's both.
I think we're still finding, and this happened 5 years ago, and I'm still hearing about it, but many people have been funded for equipment. There's mannequins and boxes sitting in the closets, and deans and directors have done a nice job maybe getting the equipment, or else funders fund equipment but not training.
Right.
Right.
But they go hand in hand. In fact, the evidence we do have from the National Council of State Board of Nursing survey, we asked how many faculty had been prepared with simulations when they conduct them. I can't remember the exact, it was 34% or 43%. It was one of those numbers. In other words, it wasn't really high. And that's the problem. And when you talk about faculty hesitation, it's a new pedagogy. It's just not about the simulator, the mannequin, but it's no longer teacher-centered, but student-centered. There's an immersion. I think the big eye-opener is students are portraying the role of an RN in most cases. We're immersing them to that scope of practice they're going to graduate, where if you look at real traditional clinical, the students are always a student nurse with the faculty, so this is a whole new role. Not even counting the role of debriefing. That art of debriefing is just totally something different, a new style. Again, it's not teacher-centered, you know, whether you do advocacy, inquiry, or whatever. But if people aren't exposed to how to do some of this, there is hesitation, and faculty need to be developed. We just met, Dr. Mary Ann Rislow and I met with Sim Leaders Group for the NLN. That's our second cohort we had this year. And usually we look at priorities for the leadership development. And it was last year and this year, faculty development was one of the leadership goals, because faculty need to be developed. And what's that look like? You can talk about a lot of training packages. Now we have the CERC website and the courses. There are 12 out there that folks can take. But many times, you know, they need more than that because you can't always drive them to go there, but you can get them, and sometimes it's a resource issue. So we've got to think more about how we can conduct faculty development within small schools versus large. And in addition, I think another hurdle, it's a challenge, I guess, not a hurdle, but deans and directors do ask, is this going to cost more? This type of education, is it going to cost more? The answer is yes. You know, time you get different pedagogy, I mean, you don't have to have the high fidelity. Many people do. They see the bonuses of that. But it's just, if you get a SIM team versus no resources, you know, that's more resources than what you had. So yes, it's going to cost differently. But if you look, our traditional education's been going the same way for 40 plus years. And we know it's not working. We hear that we're not producing the graduates we have. So something has to give. And what inevitably I hear from our faculty all over, they don't have enough resources. I probably could ask how many out there are a one-man team. You're trying to do your simulations with only, let's just say, 1 or 2 people and do everything across the school, and it's very hard. Let's just see the hands. How many out there are a one-man team and you're struggling to, you know, they're by themselves without resources, but yet have the passion and want to move this forward, but without the resources. And it's hard.
Having said that, I think one of the things that has to happen is our traditional probably 3 courses on curriculum and evaluation and teaching and learning that you might get in the 12 credits of education that you have had to have traditionally to start teaching is going to have to start including simulation. I think there's fallout from simulation because you actually have to learn something different to do simulation well, which then brings up the question, well, if you're getting all this extra training in simulation, well, what do we do for normal clinical instructors? And I usually look and say, well, that's a very good question. I don't know what we do for clinical instructors. And so inadvertently, I think that simulation is causing a fallout and a ripple effect through all of education, and that we're starting to question, well, if, you know, how come simulation gets all these resources? What about these other things? And I think that we're starting to look at all those other things and maybe pay attention to things that we haven't looked at before. I wonder if you're a really good sim instructor, I would bet you're probably a better clinical instructor because it's the same thing. So
there's skills you can transfer. If you think of debriefing skills, you can take those into the post-conference or even just in dealing with your student.
Yes.
We're talking about resources and the lack of and challenges, you know, for one-man teams, one-women teams, whatever, is the notion of developing partnerships and consortiums, particularly for faculty development. I think it's just so needed. In the state of Maryland, we got a grant. It was called a NSP2 grant, Nurse Support Practice Grant, and it's great. In the state of Maryland, I guess hospitals have put a real small % toward nursing grants, and then you can apply for them. Anyway, we developed a consortium with 8 schools of nursing going up to 10, and it's all about faculty development and simulations. It's called the MFAS, Maryland Faculty Assessment, Simulation and Technology. But it's for community colleges, baccalaureate colleges, and we're learning together. It's not just 8 different places. And if you look at where we're going, that was 1/3 the schools of nursing in the state, and you know, and continue to want to make the impact. But we have shared resources. You can get shared licensing agreement, whether it's for the CERT courses or whatever. So it's things like that that consortiums will help.
I'm talking about the consortiums because we have one also, and I know there's multiple consortiums around the nation. I think another piece that has to happen is the individuals from the different consortiums need to get together to start doing sharing, because we share amongst us, we share, again, the resources, our scenarios, etc. But we need to now broaden it out and move and find partners in other states.
Good point.
Well,
No, I
I
think-
think, go ahead.
I was just going to say, I think what the NLN is doing to support simulation is phenomenal. And I think the fact that there's so many people at this conference who are interested and willing, I think I'm very I'm very pumped about this. I think we're very close to the tipping point. You know, I think we have that critical mass of people who are interested. We know what the issues are. It's not as though we don't know what needs to be done. We know what the issues are. We've got great support. You're doing wonderful work with developing consortia and looking beyond nursing. I really think that, I think we're getting close. You know, and as far as support, you know, the NLN has provided all of us with so many opportunities. I mean, if you get involved, there's just no end to, you know, what you can learn and the relationships you can develop with folks. But my particular task group that I was on looked at innovation. And I think that everybody in the audience needs to be congratulated in terms of their innovativeness. You know, I think nurse educators are among the most innovative people alive.
Absolutely.
The problem is there are some barriers that we need to overcome, all right? And when we interviewed nurse educators from across the country who were from innovative schools, and they explained to us what they were doing, one of the biggest things they said, as far as being problematic, was support. They need the support. So it's not as though we're not smart. It's not as though we're not creative and innovative. It's not as though we don't recognize the issues, but we need support. We need faculty development.
Well, on that note, I think it's time to close. Nursing education, it's a great time to be, you know, and I think we can revolutionize clinical education through clinical simulations, as we all know, and talking about some of these points. And for the future, I think there's going to be more interprofessional education using SIMS, including within our own work, just in the nursing world, as we continue to look at team building as well. So,
Actually,
any last comments?
I do. I have something to close on. And I'm going, this actually fits.
Yeah.
We just did an editorial in Clin Sim and Nursing, and I said, bringing sexy back to nursing education. And I said, and I closed with, and thank you to Justin Timberlake for inspiring this editorial. But simulation is a large part of this conference now, and it's invigorating everything. So I looked up sexy because I wanted to know exactly what that meant, and it meant exciting and new. So hopefully we're all sexy and exciting and new and doing wonderful things.
And I think if we look at it, simulation's not just a part of this conference. The patient safety conference this year was 90% simulation. So it's giving us a tool to bring people together, to change. We're being asked to transform. And we can utilize this tool to help make that transformation happen.
Well, in closing, as Mary Ann's coming up, I want to thank the Laerdal Medical Corporation for funding the Spunt Lectureship. We've all been honored to be one of the Spunt lectures, and I know it's dear to my heart. I remember reflecting, it was 5 years ago, it was very hard. So I'm very proud to sit up here on behalf of Debbie Spunt.
Thank you so much to our panel for sharing some of their insights with us. And we have about 3 minutes for Q&A. So we've got 2 microphones in the middle. If you've got some questions for any of our panelists, please come on up and, yeah, go ahead.
Hi, I'm Valerie Howard, and I'm president of INACSL, the International Nursing Association for Clinical Simulation and Learning, and also associate professor at Robert Morris University. I have 3 quick points. Standardization and getting all this terminology together can help us progress the discipline of simulation so much. And INACSL just released some standards for simulation, which are available now. They're hot off the press. The second thing is, regarding faculty development, there are some web-based online certificate programs to help with that, so that might be a resource for many of the faculty. And the third thing is that I think as we look outside of nursing to really help us with simulation, that this really is a change movement. And if we look at organizational behavior, psychology, and change theory, that my favorite is John Cotter, My Iceberg is Melting, the 8 Steps to Change, that we can really pull that information from other disciplines into nursing to help us to make this change. Thank you. Thank you to the panelists.
Thank you, Valerie. And microphone 2 in the back.
Hi, good morning, everybody. Eileen Zungalo from Duquesne University in Pittsburgh. I want to congratulate the panel. You certainly woke me up. but I'm afraid my juices are all riled about a number of things. First of all, when we look at the kinds of things that directors of nursing service complain about our graduates, I think we need to begin to question some of those criticisms as to whether or not they are valid. The one that always drives me crazy is the one about new graduates not being able to delegate. I personally was afraid to talk to an aide for about 2 years. So I think we need to put that into some sort of perspective. If a director of nursing says that's not a good, they don't do this, I think we need to say it is not realistic for a 20-year-old person to come into a brand new job and be able to delegate to people who've been there 30 years. The other thing that's really of concern to me is our focus on faculty development vis-a-vis simulation. We need to keep in mind that simulation is a teaching methodology. It is a way to help our students learn. Faculty need to be developed across the board so that they can critically and seriously select what could be learned through simulation and what needs a different kind of learning experience. So I know that the panel knows that I'm a strong supporter of simulation, but we need to give equal or at least some consideration to other forms of teaching and to help our faculty develop along those lines. Believe it or not, I loved your presentation.
Thank you, Eileen. And first microphone. Is
Shannon Perry, retired from San Francisco State University. One very quick question. You gave us a reference of Spiro and 2 other authors, and I didn't hear their names, so would you repeat that, please, and where it was published?
Yes, Spiro, Feltovich, and Colson. I think Jacobson is another one. If you just type those into Google Scholar, their work will pop up.
We have a reference list we gave out.
Yeah, but it's not on that one, I don't
It
believe.
wasn't on that one?
Yeah.
But we're going to post a reference list on
We'll update it.
CERC
We'll update it.
website.
Update it.
And one last question in the back.
Patricia Underwood, Case Western Reserve University, and I was so delighted at your blending of simulation and interprofessional education, because we have a big Macy grant on IPE. But I just wanted to say 2 references people might want to look at least one theory. David Kolb's experiential learning, and a reference James Zull, Z-U-L-L, The Art of Changing the Brain. It's not a real big book, but I think it really is fascinating, and it helps give us some underpinnings for the kinds of things that we're talking about now.
Thank you.
Thank you.
I just want to conclude this session with our thanks to Laerdal. We actually offered them an opportunity to come up here and say a few words, but in their typical humble fashion, they declined. During all of our work together, from the original 2003 to 2006 multi-site study to the project that developed the SIRC, the current ACES project that has developed the unfolding cases. If you haven't met Millie and Henry and Eartha and Red and Julia and Lucy, we invite you to go look at them on the NLN website. And our current project that's investigating the use of simulation for high-stakes assessment. In all these projects, Laerdal has been a supportive partner and has never asked for any recognition for their generous contributions. It has really been a privilege to work with them and a pleasure. And I invite you to look on their website at their company values and vision. These include pride in the history of the company, which is focused on listening, respect for the customer, and hard work. Having a clear vision and a meaningful purpose, and that is saving lives. Commitment to an excellent reputation that involves collaboration with users, a willingness and a desire to learn and walk the extra mile, and a passion for continuous improvement, which involves thriving on challenges, building trust through mutual respect and honesty. And while you're there, take a look at their new company, Laerdal Global Health, that has been established to help developing countries reduce maternal and infant mortality with its low-cost, non-mechanized simulators, Mama Natalie and Baby. So please join me in thanking Laerdal for all they've contributed to saving lives. Thank you. So thanks to our panel of experts for sharing their expertise and for all of you for being here this morning. We're going to have a short break. Don't go too far because at 9:45, right back in this room, we're going to start our town hall meeting. Thank you.